All right, hello everyone. We're going to go ahead and get started. So welcome to the third webinar in our series being offered by the Society of Counseling Psychology as part of Dr. Mary O'Leary Wiley's presidential initiative focused on practice engagement. We're really excited that hundreds of practitioners have joined us today to learn more about sex positivity, what it is, and why it's essential to your practice. My name is Dr. Christopher Stultz. My pronouns are he, him, and I'm the chair-elect of the section for the professional practice of counseling psychology. Just a quick housekeeping note, please remember that you must be present for the entire webinar, which is going to be 60 minutes to receive CE credit. I will be sending more information about the CE credits after the webinar via email. Also, during today's webinar, you can ask questions using the Q&A function here on Zoom, but we do ask you to save your questions for the end, as Dr. Mintz may address your questions before the end of the presentation. Following the webinar, I will be sending a link to access the PowerPoint slides, as well as a really helpful resources page. Today's webinar is also being recorded and will be available in a few days on the Society of Counseling Psychology's YouTube channel. Now I'd like to introduce our esteemed presenter. Please welcome Dr. Lori Mintz.
Thank you so much, Chris. I appreciate the introduction, and I appreciate so many of you being here to learn about sex positivity, what it is, and how it's essential to your practice. Just to briefly tell you my qualifications for giving this webinar, I am a professor at the University of Florida, where I teach the psychology of human sexuality to hundreds of students a year. It's really fun, one of my favorite things to do. I'm a licensed psychologist in 4 states, a certified sex therapist in the state of Florida, and I'm the author of 2 books, both aimed at empowering women sexually, and one of them covering one of the most common concerns that women bring to sex therapists, and that is low desire, the other covering this other most common concern, difficulty orgasming with a partner. Speaking of those books, let me tell you that that is a conflict of interest, although a very slight conflict of interest. I will be talking about or referring to these books occasionally, but the reason it's a very small conflict of interest is because I don't yet get royalties on one of the books, and the royalties for the other is less than $1 per book. So I'm hoping that you will see that I talk about it because of the knowledge involved, not because of any money that I may earn from this. My goal here is to educate you. Speaking of goals, let me briefly go over the learning objectives for today. And the first is to describe sex positivity and how it's essential to therapy practice. The second is for you to understand the evidence-based implicit model of treating sexual concerns. And the third is to list evidence-based treatments for a few common sexual concerns, and knowing where to get information on the others. And depending, we might not get to much of 3. However, what I will tell you is that in an hour, I couldn't do that. I give up 3 to 8 hour webinars on just one of these concerns often. So in an hour, we're only going to just whet your appetite, and that pun is intended. And I'm going to make a lot of those puns, and that's sort of fun. And I'm also going to speak very explicitly about sex and sexuality. And if this is your first training, that might make you uncomfortable. But I guarantee you cannot be a sex positive practitioner until you get comfortable saying words like masturbation, penis, clitoris, orgasm, etc. So let's get going. As a context for sex positive practice, I need to define sexual health. And the World Health Organization says that sexual health is a state of physical, emotional, mental, and social well-being related to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual responses, as well as having the possibility of a pleasurable and safe sexual experiences free of coercion, discrimination, and violence. So with that definition in mind, I'm going to take you through two very quick internal self-assessments that may get you thinking about what is safety, what is pleasure, what is coercion, what is violence, what is sexual health. And of course, if we were all in a group, we could talk about this, but in an hour with you all in the safety of your computer screens, just do some thinking, honest thinking. So the first internal self-assessment, I'm going to read you a short vignette based on an actual client of mine, but disguised, of course. And then I'm going to ask you to think about this and answer some questions. Andrea is a 28-year-old woman who identifies as Asian American. She's been your client for a while, and the main focus of treatment has been recovery from sexual abuse that occurred when she was 12 to 16, with the perpetrator being her stepfather. She's made good progress in treatment. She comes to a session and tells you she's met a new man who she likes, and he's introduced her to the world of BDSM. Specifically, during sexual encounters, he likes to tie her up, spank her, use demeaning verbal words, and force her to do sexual acts, all with a safe word implemented so she can stop the play at any time. She's finding this extremely erotic and arousing, and at the same time feels extreme shame around this. The shame is general, just that this is wrong and dirty and I shouldn't like it, as well as shame due to her sexual abuse. She said, asked me, is this why I like it? Because I was sexually abused. And she is also experiencing great shame due to what she describes as living out the sexual stereotypes of a submissive Asian woman. So give some honest thoughts just for a second to your reactions. Do you feel worry about her enjoyment of this activity, both due to her trauma and her identity? Are you thinking it might be a good treatment outcome to help steer her away from this type of sexuality? Are you personally feeling uncomfortable with the idea of BDSM? Just take 1 minute and just give yourself a moment to be honest with your own reactions. Okay, if you had any of those reactions, it is totally normative. Those are very normative reactions for a psychologist, but it's not sex positive practice, nor is your reaction based in research or clinical writings. Briefly, the research on BDSM shows that BDSM practitioners are healthy as non-BDSM practitioners, and in many ways healthier. For example, more on the big five, they're less neurotic, more open to new experiences. And they actually have been shown to have better sexual responsiveness and higher degree of communication and consent because of the use of the safe word, pre-negotiated boundaries, etc. Also, contrary to what your initial reaction may have been, rather than representing traumatic reenactment, there is a wealth of clinical writings indicating that BDSM can facilitate profound healing of past traumas by providing a safe and controlled space for participants. Now, obviously, we could do an entire 5-hour CE on working with clients who are experiencing or experimenting with BDSM. But this is one specific area of practice. But the point of this exercise wasn't really to teach you about BDSM. It was instead to say that for sex positive practice, it's essential to evaluate your own attitudes and put them against the science, basically. Also, in terms of the part I presented in terms of her Asian American identity, I want to just say that while writings on sex positivity and intersectionality are at their infancy, one of the most useful concepts, I believe, was created by Dr. Candace Hargens when she presented it at an APA conference in 2018. What she did is she took the idea of stereotype threat and applied it to sexuality. Stereotype threat is a situational predicament in which people are or feel themselves at risk to be conforming to a stereotype about their social group. And if in terms of sexual stereotype threat, if you enjoy stereotype sexual behavior, but avoid it to not wanting to conform to the stereotype, there is a risk you might be constricting yourself sexually. On the other hand, if you're enacting stereotype sexual behavior without thinking about it or compulsively, the risk is diminishing your own desires and wants. And it's very difficult and confusing with clients sometimes to have these conversations because sometimes they don't know and there's in-between situations. But it's really important to be aware of this when working with clients and to be culturally mindful of sexual stereotype threat. A second case example, I'm currently working with a cisgender man who identifies as Black, and he is in a new and very serious relationship with a white woman, and he started having erection issues for the first time in his life. And as we explored that, we could discover that it was due to sexual stereotype threat. He felt that his new partner was sort of expecting him to, conform to the sexual stereotypes of a Black man. He didn't feel he wanted to, nor did he. And what helped was realizing that and then having a really wonderful and open conversation with his new partner. So again, speeding through some of this, but really important. Okay, also to emphasize, why am I going through all this? Because if you were to become a certified sex therapist through ASECT, which is one of the major accrediting bodies, and I'll talk about that later, you would have to do, I think, about a 48-hour intensive sexual attitude reassessment. So doing some of the exercises like we just did, but at a really deep level. And I share that to emphasize just how important, we all know as psychologists, our own biases and values are important. That's part of our training. But this is a whole new area to really look at your values. Because being sex positive doesn't mean you're positive about the narrow window of sexuality that you like. Being sex positive means that you are embracing and affirming of all sexual practices as long as they are pleasurable and consensual. Okay, on to the next short internal assessment. Just think about these answers in your head again. Have you ever worked with a depressed client? I'm guessing all 299 of you have. We know that depression includes a loss of interest in pleasurable activities. And sex is a pleasurable activity for most of us, hopefully. And if not, hopefully you will learn to help people find that pleasure. But the point is, have you ever explicitly asked a depressed client, how has your depression affected your sexual pleasure or your sexual interest? Also, have you ever recommended to a depressed client that they seek out antidepressant medications? If so, have you discussed with them the sexual side effects of these medications? Because we know that SSRIs diminish and inhibit orgasm. All right. Next one. Have you ever worked with a client with poor body image or an eating disorder? Have you explicitly asked that client, how does your body image affect your sex life? I could do this on and on. Anxious clients, survivors of abuse, but I think that you get the point. The point is to ask your clients about sex routinely. Nevertheless, if you answered no, you are far from alone. This is the status of the profession, which is a reflection of culture. We ask our clients about other intimate details. How do you feel about your parents? Do you take drugs? Do you drink alcohol? We have discussions about culture and religion, but often we shy away from the area of sex. We often don't ask about it in general, or even in the context when it's part of the issue: depression, sexual abuse, coming out, body image. And this is a big takeaway point, is to simply ask your clients, every client who walks in your office, about sex. I had a friend and colleague who was a therapist I respected greatly until one day when she said to me, "Oh, you ask about sex? Oh, I never do. It's too private." I stopped referring to her because therapy is a place, as you all know, to speak the unspeakable. And clients won't bring up the topic of sex unless they know that you're comfortable. And I find now that I ask, well, in my situation now, most people come to me for sex therapy, but before that time, I would find that if I asked, 85% of clients would say something along the lines of yes, but I wasn't going to bring it up until you did. So the ask, but you might want to be asking like, well, how do I ask? I will, here is what here's a few things. This is from Stephanie Bueller, who I'll talk about later. So basically, may I have permission to ask you a question about sex? It's something I ask all of my clients. Is there anything about your sex life that would be important for me to know in order to understand you? Are you satisfied with your sex life, or are there problems that get in the way? Would it help you to know that sex is spoken here and that you can ask me questions about sexuality if there's anything you would like to know? These are authored by Stephanie Bueller. I'll give you a link to her book later, which is entitled What Every Mental Health Practitioner Needs to Know About Sex. But let me read you two quotes of Stephanie's that I think really speak to this. First, asking every client who comes into your practice about sexuality is an excellent idea. Learning that your client has a sexual issue might make treatment more effective. Since sexual issues might be the embarrassing, shameful, or unseen factor driving or exacerbating other mental health disturbances, it is critical for therapists to overcome his or her reticence and ask these questions. Stephanie goes on to say, doesn't it make sense for psychotherapists to be able to assess not only mental health, but also sexual health, especially when the two go hand in hand? Many clients who I treat in my sex therapy practice have been in prior therapy with therapists who told them, quote, "I don't do sex." Like Stephanie, I've also seen many clients, especially couples, who leave their couple therapist because their couple therapist tells them they don't do sex. I maintain that it's really impossible to do effective couple therapy if you are not comfortable asking about sex. Sex may be an underlying problem that is driving other problems or reflecting other problems. Okay, so now you hopefully have some idea about what sex positivity and sex positive practice are. And so there's many definitions of sex positive practice, and none of them are great. None of them are as good as the World Health Association's definition of sexual health. But I do like this simple definition of sex positivity by Chris Donahue, who wrote the book Sex Outside the Lines. Sex positive individuals and therapists and communities emphasize openness, non-judgmental attitude, freedom and liberation about sexuality and sexual expression. Okay, with that definition in mind, let's turn to some more specific sex positive learning. First of all, you've probably seen the genderbread person, but maybe some of you have not. And to be a sex positive practitioner, you must be affirming of all sexual orientations, gender identities, gender expressions, and relationship styles. This is a new part. And also types of sex, the kink and BDSM that we talked about earlier. So this is a great thing. This is a great illustration of those that we may have been born with our genitals one way. We might have been born with a penis and a vulva, but that doesn't mean we identify with that sex. I might have been born with a vulva, but identify as a man or gender queer. Also, your gender expression, how you present yourself to the world. I'm working with a client now who was born with a penis, identifies as a woman, but presents himself to the world as a man 90% of the time, a married man with children, and only about 10% of the time in very safe spaces will present himself as a woman. We already went over biological sex. Certainly most of you are familiar with sexual orientation. And there's way more orientations now. When I did this lecture in my human sexuality class, there's like a list of 20 orientations. So knowing all of that, and then commitment style. Not everyone wants to be monogamous. There are some people who only want casual sex. There are people who identify as non-consensual monogamy. So it's not cheating. It's not that they're saying, oh, I'm going to be monogamous, and then they're not. They're consensually non-monogamous, and that can range from a polyamorous relationship where, say, there's three people in a relationship, or it can be an open relationship. So just familiarizing yourself and looking at your attitudes about all of that, so that you do not negatively affect your clients. Okay, now let me talk about a really important model of treating sexual concerns. This is called the Implicit Model for treating sexual concerns. It was created by Jack Annan way back in 1974, and it is still incredibly relevant today. And I share it with you because it cuts across the treatment of all sexual concerns. And basically, Annan initially presented it as a stepwise model. However, more recent thinking indicates that it's really more of a circular model, and all of these different treatments can be going on at once. And there's even a new model. I love the pun. It's called the explicit model. And what it says is that permission is at the core of all treatment of sexual concerns. Much like we say empathy, positive regard, the relationship is at the core of therapy. This says permission giving is at the core of all, but we must go beyond permission. So let me give examples. So permission is basically like the client in the vignette, having a sex positive, knowledgeable expert explain to her that what you're doing is fine. It's okay. It's okay to enjoy it. So it's really just giving permission for people to let go of shame and enjoy what they enjoy. I always try to have available some sex positive religious leaders, and there's some famous ones who will talk to people, and sometimes you can find them in your own town, because sometimes that shame is so steeped in religion that it's helpful to have a religious leader, not just your therapist, be giving of the permission. Limited information. There is so many myths. Oh my gosh, so many myths are abounding about sex and sexual functioning. And sometimes simply giving people information can help them. So for example, I get calls from people who identify as men, people with penises, and they will tell me they want to see me for premature ejaculation. So I will ask them, tell me what you mean by that in the 15-minute consult that, I usually do with new clients before taking them on. And I'll say something like, well, it takes me like, I put my penis in my partner's vagina, or they usually say it a little less scientifically than I am. They usually say like, I come within 6 minutes of when I start sex. And I'll have to say, what do you mean by sex? Da, da, da. And then I simply say, tell them that there is, the studies show that the average amount of time from inserting a penis into a vagina to ejaculation is anywhere from 3 to 6 minutes. And I say, you do not have premature ejaculation, and you really don't need to waste your money on me. And sometimes that's all they need. And so that's limited information is very helpful. Specific suggestions often comprise the mainstay of therapy. And so, for example, a client with a vagina who cannot orgasm through penetration, suggesting finding out how she masturbates. 99% of women masturbate by touching themselves externally, either alone or coupled with penetration. Less than 1% of people with vulvas masturbate with just penetration. So suggesting to that client that they get the same type of stimulation alone as with a partner is a specific suggestion. So those are just a few examples. And then, of course, intensive therapy. And Jack Annan said, and I tend to agree, and I've seen it borne out in clinical work and research, that 80 to 90% of sexual problems can be solved without intensive therapy, with just permission, limited information, and specific suggestions. Certainly recovery from sexual abuse, trauma, other forms of sexual trauma, not being attracted to one's partner anymore, an affair, those kind of things require intensive treatment. And so obviously I can't give you all of this in a short time. I do want you to start thinking in this model, in this framework. And I also want to give you a few foundational pieces of treatment knowledge. First of all, sexual myths versus facts, the information part. It's really important to have a grounding in this so that you can correct misinformation. How do you do that? Besides attending this webinar, which I don't have enough time to give you all this information, read sex positive literature. And it doesn't even have to be scientific literature. I think the best book, and I have this on the resource list, is a book for lay people called The Guide to Getting It On. It is an encyclopedia of sexual information written in a fun and funny way, and you will get that information you need to be able to debunk myths such as sex should be spontaneous, simultaneous orgasms are the goal. Those are both myths that you need to be able to debunk. Here's just an example of how I debunk the sex should be spontaneous. I say, do you remember, this was pre-COVID, okay? Do you remember like getting dressed to go out? Say I'm talking to like a college student type client who thinks this. Yes. I bet you took a shower. Yeah. Put on your fancy underwear. Yeah. Made a little perfume maybe. You kind of had a drink. You flirted. You touched each other's hands and arms, and the night ended in sex. That's not spontaneous. That's well orchestrated. So well orchestrated that you even think it's spontaneous. And to treat some concerns, we need to let go of these myths. So that's why it's good to know that information. We also need to intervene in sexual shame. So many clients are so ashamed, and you need to intervene with sex positive information and permission. Many things, one of the most shameful areas for people is their sexual fantasies. The most common sexual fantasies are more than one partner and forced sex. And to be able to tell people that there is a difference between fantasy and reality and how common these fantasies are, and help them let go of shame. And there's a great book all about that called Tell Me What You Want by Justin Lee Miller. And then mindfulness. I'm assuming you all know what mindfulness is. It's, putting your mind and your body in the same place in time. And it's also essential. Teaching mindfulness first in life and then applying it to sex is one of the most essential ways of treating many sexual concerns, because so many sexual concerns are due to what we call spectatoring, which isn't watching other people. It's like going outside your body and watching yourself. Do I look okay? Do I smell okay? Am I gonna orgasm? Is it taking too long? Are they bored? Is my stomach sticking out? I guarantee you cannot orgasm with your mind like that, right? So teaching clients mindfulness. And here's a really fun fact that I love. Right before orgasm, brain scans show that our brain enters in a brain state almost identical to that of deep mindfulness meditation. Being able to turn off your brain is essential to enjoying sexual pleasure. And there's a great book by Lori Brado, who was the person who introduced mindfulness to sexual health, called Better Sex Through Mindfulness. Also important to know about masturbation. And there's a lot of shame about that, but sharing statistics about how many people do, and that it's sexual and health benefits, which are way too numerous to even go over here. There are so many. And sometimes it's even helpful, and I go over this in Becoming Cliterate, to know where the religious objections to masturbation come from and be able to debunk them. They come from a story in the Bible where Omen spilled his seed, but some Bible experts say, no, he wasn't masturbating, he pulled out before he ejaculated. So being able to have all of this knowledge and help people is incredibly helpful. Additional knowledge is being able to teach communication, general and sexual. Knowing about genital anatomy and sexual response. Just a few. It's important to know that only 4% to 18% of people with vulvas orgasm from just penetration alone. The concept of receptive desire is essential. So what is that? We probably, some of you at least, probably learned the idea of desire. First, you feel desire, AKA horny. Then you engage in a sexual encounter and you have arousal. Then you have orgasm, and then you're done. Well, that horny thing, that is called spontaneous desire. And there's another type of desire called receptive desire, which is your body might not have any interest, but your mind is receptive to the idea of sex. I know I'll enjoy it once it gets going. I know it'll be fun. But so many times people don't know this. And so they stop feeling physical desire and they stop having sex. And helping people understand and use receptive desire is incredibly important to treatment. And the ejaculatory latency times, these are just a few examples of things that are important to know. And then also there's something called sensate focus, which is essential to know. And there's an excellent book, and these are all on your resource list as well. Sensate focus is a series of, and it's best tailored to the client, but it's basically a series of exercises that help clients get out of this goal-oriented view of sex and into a more mindful, connected, pleasure-focused sex. And you take any sex off the table and you take the clients through a series of exercises. It starts really small. I start with a face massage, feeling their partner's face, moving on to maybe cuddling with clothing, moving on to touching through clothing. I mean, moving on slowly and then examining reactions and really teaching. You take turns as the giver and the receiver in this exercises, and really teaching and helping the clients focus on their sensations, their pleasure, both as the giver and receiver. And it's a mainstay of treatment. Also to know, not a sexual problem. Permission and information is all that is needed. Many clients will come to you with both issues of shame or discrimination about their sexual orientation and gender identity. And what you need to be able to do is not treat those as a sexual problem, but use permission and limited information. A case example is, I have a client who is trans, but was raised in a very strict Pentecostal household and had so much shame around his gender identity and knew that his family would disown him. And in fact, this client ended up getting cancer, and his family did find out and told him that his cancer was due to him being both gay and gender nonconforming. So being able to really intervene with those kind of issues with permission and limited information, both in terms of gender identity and, again, polyamory or consensual non-monogamy. All right, now we will not have a lot of time, obviously, to do this, but let me just go over some of the most common sexual concerns, and I'm going to briefly illustrate the implicit model with treatment for a few of the highlighted ones. The most common couple problem is mismatched desire, although it's often diminished desire in one partner. And usually you see a couple come to treatment with one person identifying as the patient. Mismatched interest in sexual activities. One person really likes something and it's really what turns them on, while the other person finds that repulsive. Vulva owner problems. I'm intentionally, of course, using inclusive language. Difficulty with orgasm, lack of arousal, sexual pain, or vaginismus. FYI, we now know that most sexual pain disorders are medical, not psychological, and you need to refer to a sexual medicine physician or a pelvic floor physical therapist, or both. Vaginismus, which is when the muscles around the vaginal opening constrict and nothing can get in. That's the only sexual pain disorder that we now know is more psychological. Penis owner problems, premature ejaculation, coming too soon without control, erectile issues, erectile dysfunction, and delayed ejaculation. We often don't hear about it, but it's not uncommon for a person with a penis to say, I can't ejaculate with a partner. I can only do it on my own. And then, of course, there's the whole porn concerns. Is it a fun pastime or is it an addictive rabbit hole? Wow, that's way beyond this. But I will tell you that the main sexuality association, ASAC, is against the term addiction for sex. And you can talk about compulsive sexual behaviors. You know, is it interfering with your life? Are you missing work, school, etc.? But what we're finding increasingly is the biggest issue is not necessarily the porn, but that the porn is inconsistent with the values. That most people who say they're a porn addict don't necessarily watch more porn than people who say who don't identify that way. They are just more morally opposed to it. So if during the Q&A, you can ask a few questions about some of these, but just to go over a few things. For example, if you come across a client with mismatched desire, the information that you can give them include the emotional, physical, and relational benefits of sex. Huge, important, receptive desire. I have a lot of clients say, well, it's fun when it gets going. And, then I think I should do it more often, but I don't. And I'm so ashamed of this duty sex. I tell them, no, if it's fun, it's not duty sex. Or if they're not doing that, I tell them, reverse the equation. Have sex to get horny. Don't wait till you're horny to have sex. Specific suggestions. Think of sex when you're not having it. I sometimes have clients set alarms and think sexy thoughts. Turning off the busy brain when you are having sex. Mindfulness, time strategies, self-care. Actually, yoga has been correlated with enhanced desire and orgasm. Why? I think it's because of the mindfulness and body focus. Chore play. We know that a lot of times a partner loses desire because they're doing too much of the work. So we talk about chore play. A big one is scheduled sexual encounters, what I like to call trysts. And again, you have to be able to debunk the myth of spontaneous sex. So you can see how this implicit model runs through all of this. Novelty. Sometimes people are not bored of sex, but they're bored of the sex they're having. So being able to suggest things like ethical porn, erotic literature, lubes, vibe, kink, games, seeing if that experimentation helps. And of course, then intensive therapy if the low desire is due to any of those things here, loss of attraction, affairs, a sexual secret. Difficulty with orgasm. I'm just going through a few of these common ones so you can get a sense and hopefully see. Honestly, I love doing this work because you can make such a difference with some pretty basic interventions. Difficulty with orgasm. So information, teaching genital anatomy and teaching how this is for people with vulvas. This is from my book, Becoming Clitorate, research I've done with thousands and thousands and thousands of women asking, what's your most reliable route to orgasm? And you can see that for 96%, it involves clitoral stimulation, either alone or coupled with penetration. So giving that information, suggestions, making sure they get a medical and medication workup just to make sure that perhaps they're taking a medication. A little known one is antihistamines. They dry out your nose, right? Well, they also dry out your vaginal tissue. And if sex hurts, you're not going to want to have it, and you certainly aren't going to orgasm. Sex positive thinking, including thinking that I'm entitled to pleasure. A lot of orgasm issues are feeling not as entitled as one's partner. Mindfulness, here we go again. Guided masturbation. No, you do not do that with them, obviously, but you sent them home with a prescription to masturbate, including with lube and vibrators. Many people with vulvas do not orgasm till they use a clitoral vibrator, and being able to debunk myths about them being addictive or replacing partners. Changing sexual scripts, helping them let go of the foreplay, if they're heterosexual, intercourse, sex over script, to more scripts like she comes first with oral sex, then he comes through intercourse, or she comes second, enough arousal for intercourse, he comes, then she uses the vibrator on herself while he holds her. Sexual assertion and communication, being able to tell a partner what one wants. So those are some specific suggestions. Premature ejaculation. Again, here's the information on the average time to ejaculate. You just learned it was 3 to 6 minutes. And the treatment of choice, interestingly, you remember how we said antidepressants diminish orgasm? That's why they're a treatment for premature ejaculation. That you work with a doctor who prescribes a very low dose antidepressant while you teach the client ejaculatory control. So when people with penises orgasm, there's a point of what we call ejaculatory inevitability. I describe it as the I'm gonna come feeling. And you teach the client to identify that and to stop themselves, slow down, even squeeze the head of their penis before that. And then as they learn that control, you wean off of the antidepressant medications. I told you about this. If they're working with a partner, instead of squeezing the end of the penis, you instruct the partner to have a quiet vagina, just be still for a minute until you communicate to resume. Often clients do it on their own first with the squeeze technique and then move into the quiet vagina. And why did I have, going back a slide, why did I have that book there, Coping with Premature Ejaculation? It's because of the implicit model. Bibliotherapy is a mainstay in treating sexual concerns. And it's also a great way for you to learn about treating sexual concerns, because we know only you can give intensive therapy, but books can give permission, limited information, and specific suggestions. And in meta-analyses, bibliotherapy has the largest effect size, the biggest effect for sexual concerns over any other concerns. Oopsie, I'm going the wrong way. There we go. And here's both of my books, Becoming Clitorate, and then there's a book called Becoming Orgasmic by Joe LaPiccolo, have randomized clinical trials supporting them for orgasm issues for women. Both my book, A Tired Woman's Guide to Passionate Sex, and Catherine Hall's book, Reclaiming Your Sexual Self, have randomized clinical trials associated with them for enhancing desire. So those are some empirically supported books. And as I mentioned, I think the best overall book, I call it the Sex Bible, is The Guide to Getting It On. And it's so fun. I mean, these are fun books to read. So you can really educate yourself by reading a book called The Guide to Getting It On. My two top recommended professional books for you are Stephanie Buehler, who I quoted earlier, What Every Mental Health Professional Needs to Know About Sex, and then Principles and Practices of Sex Therapy, which is in its 6th edition, has a chapter on just about everything we've talked about today and more, if you prefer to read professional books. Also, professional organizations to get more involved, the Society for Sex Therapy and Research. I'm honored to say I'm the incoming president of that organization, but it does require an application and support from a member. You have to already be in the field. The American Association of Sex Educators, Counselors, and Educators, ASEC, they're the main accrediting body if you want to become certified, but you can join without certification. And I'm telling you, I've learned a lot just by lurking on the listserv. There are so many interesting case examples and case discussions and of course, all of these organizations also have conferences that you can attend. And the International Association for the Study of Women's Sexual Health also requires an application. So if you want to get involved, I'd say join ASEC, lurk on the listserv, read the Guide to Getting It On, read these books. It's fun and easy learning. Also, additional training and certification, please check your state laws. So far, however, Florida is the only state that addresses this in the laws. and they require 150 hours of education prior to saying you are a sex therapist in your website or your written materials. That doesn't mean you can't use sex therapy techniques. That doesn't mean that if you leave today and learn and that you can't discuss receptive desire with a client. You can use what you've learned, you just can't use the title. And there's some selected additional trainings and certifications. TZK Seminars has every month or so sex therapy for the general therapist, and then one I teach called Treating the Two Most Common Sexual Female Concerns. Modern Sex Therapy Institute, you can get ASEX certification, Florida certification, take individual courses. Stephanie Bueller, who I've quoted, and I put her book up, the Bueller Institute. There's individual courses as well, such as like treating, one disorder or another, or she does ASEX certification. And PESI has standalone courses with some excellent experts, including Joe Court, who's an expert in treating men who identify as gay, and Barry McCarthy, who wrote the Premature Ejaculation Self-Help book I put up, as well as a book on treating erectile dysfunction. And that is the end of my long-winded but quick overview of sex positivity and why it's essential to your practice. I hope you're convinced it is. I hope you're excited to go do some more learning. And now I'm open to taking some questions.
Well, thank you so much. That was so amazing. I could maybe send you some of the questions now. So one question that an attendee wanted to know is if you could talk a little bit about the impacts of medication on sex drive and how to address that with our clients.
That's such a good question. Okay, so there's many medications that affect sex drive. There's many medical disorders that affect sex drive. Antidepressants, obviously, we've talked about, antihistamines, cancer treatment drugs. In the webinar that I give for TZK, I go on the desire part, I go through all of the medicine and talk about it. And basically, that's the tricky one, because you can't tell someone, nor should you, to stop a medication. But you can have them talk to their doctor about alternatives with less side effects. Also, for example, with antidepressants, there's a few things that can be done. There's something called maca root, which comes from Peru. And we know that sometimes if you can take it with antidepressants, it lessens the effects. There's a couple of types of vibrators that use sonic waves to stimulate the clitoris that have been shown, at least for women, to even be able to assist with orgasm, even on antidepressants. So it's a case-by-case discussion and talking to the client about it and talking to their physician and having them talk to their physician. And sometimes there's things to be done. And sometimes it's having a conversation about accepting the sexual functioning because of the disease. And there's a person named Lee Phillips who does a lot of writing on sex and chronic illness, and looking into some of his work would be really important too.
Great, thank you.
Sure.
Another question from an attendee was if you could speak to how cisgender male therapists who may want to talk to their female identified clients about sex, how to go about that in a way that may be perceived so that the questions are appropriate to the client.
Yeah, this is one I hear a lot. And I think it's a lot of cisgender male therapists shy away from that because for really good and obvious reasons. So I think obviously it's, best done in the context of a good relationship, but even early in the assessment to acknowledge the difference and to say, I am your therapist. I am here to talk about everything in your life, even things that are uncomfortable to talk about, both in general and might be more uncomfortable to talk to me about because of our gender difference. But I'm going to ask you sexual questions if you're comfortable with that, because it's an essential part of your overall well-being. And my job is to help you with your well-being. Also, you can say, if you are having sexual problems and our identity difference makes it just like you would with any other identity difference, talk about it and offer to refer. Like tell the client, I care more about you and you getting well in all aspects of your life than you seeing me. So if sex is an issue and it's uncomfortable to talk to me, I will help you find another therapist. So straightforward, affirming, comfortable. What I find in training therapists, honestly, is that the therapist is usually more uncomfortable than the client and more afraid. So it's a lot of practice, a lot of you getting comfortable yourself. No, this is not sexual harassment. This is not you being nosy. It's you doing your job. And I'll even say that with, even though obviously the societal power coercion dynamics are different, with my clients that identify as male or have penises, I have the same conversation. And I say, is it uncomfortable to talk to me about it? I tell them, I can guarantee you I'm not uncomfortable with anything you can say to me. And so that's where that training of comfort comes in. For you to exude comfort is going to make it less awkward. Great question, though.
Yeah, absolutely. I think we've only got time for one question. There's so many great questions in the chat box, so I encourage folks to perhaps, reach out after the presentation, or certainly to access the resources that you provided afterwards. Another attendee wanted to know how you can be a sex positive therapist when you're working with either adolescents or youth, and sort of how to navigate any potential cultural or family factors that may be involved.
Oh, whoa. That's like a whole seminar in and of itself, right? Because of the the confidentiality and the under 18 and all of that. And honestly, I don't work with anyone under 18, so I'm not in a great position to answer that. But I do know that I have some colleagues who do, and who tell parents as part of their informed consent is that if your adolescent talks to me about sex, I will encourage safety and consent and pleasure, but I will not discourage sexual activity or instill sexual shame. And if I'm not the therapist for you because of that, then and actually put it in their informed consent.
Yeah, absolutely. I can see how that would be like you said, a topic that could be a whole new webinar, basically. Well, I just wanted to thank you so much, Dr. Lori Mintz, for being here and presenting this great information. Is there anything else you'd like folks to know before we wrap up?
No, I'm just so delighted with the turnout. I certainly hope you learned something. Certainly feel free to email me with follow-up questions. I'll be honest, I just got back just today from a week and a half in the woods with no internet. So I've got hundreds of emails to return. So there may be a delay, but I have what I term overly responsive disorder, which means that I will respond to your email. So feel free to email me as a follow-up, because clearly there's a lot of questions and that we didn't get to. And I hope that it's a really, really fun area of practice, a meaningful area of practice. And once you start, at least for me, I feel like a sex nerd. There's all these like facts of sex in my brain. It's really fun stuff to learn about. So I hope I've encouraged you to do that learning.
Absolutely. Well, thanks again. And thanks to everybody for attending today's webinar. As I said earlier, We'll be sending out information on how to retrieve your CE credits within a few days following the webinar. And we hope everybody has a great rest of their day and evening. Bye, everybody.
Bye.